Good afternoon, everyone. I hope you are keeping well, and thank you very much for spending your precious lunchtime with me. I would also like to take this opportunity to thank ACTRIS for giving me this chance to participate in this cell therapy webinar seminar. In particular, to Lip Kun and Sudipto for your support and collaboration. I understand that we have a very broad audience today, and the seminar series is meant to be both educational and scientific. I have therefore divided my talk into two parts. Part one will be an introduction to regenerative medicine and also to Parkinson's disease. And I shall provide an update on past and current efforts in regenerative therapies for Parkinson's. Now, in the second half of my talk, I would like to share with you our very own work on using umbilical cord lining derived cells as a novel source for regenerative medicine for Parkinson's. And this work is principally driven by Dr. Chai Chow, a very talented senior scientist in my lab at LKC Medicine. So please pardon the background noises of the fighter jets flying around. I'm working from home today, like many of you. Now, as many of us are aware, regenerative medicine holds promise, you would agree with me, to repair, to replace, and regenerate tissues and organs affected by injuries, by disease, or even natural aging process. And I think we are living in exciting times now. So depending on which report you read, the global regenerative medicine market is estimated to reach 40 billion in a few years' time, with a compound annual growth rate of more than 30% from 2017 to 2023. So currently, the market is segmented into the following areas. So small molecules and biologics, such as those that could regulate stem cell production and differentiation, or modulate their differentiation or fate in vivo, that represents one area. Gene therapy is another area. So notably, in 2016, the European Commission actually granted market approval to GSK for ex vivo hematopoietic stem cell gene therapy for the treatment of adenosine deaminase deficient severe combined immunodeficiency. This is a very rare congenital disorder of the immune system. The new medicine is actually known as Shrimvalis. It's what we call an advanced therapy medicinal product, or ATMP. Tissue engineering actually evolved from the field of biomaterials, and it refers to the combination of scaffolds of cells, biologically active molecules into functional tissue. So artificial skin and cartilage actually are examples of engineered tissues that has been approved by the FDA. And of course, we have cell therapy, the focus of my talk today, that arguably has the most promising future due to its efficiency to restore the lost function of tissues and organs. So some examples of regenerative medicine products are shown here. So Vericell has a procedure known as MACI, or matrix-induced autologous chondrocyte implantation, in which a patient's own cells are used to regrow new cartilage for the knee joint. So this was approved by FDA in December 2016 for the treatment of symptomatic articular cartilage defects of the knee. And alongside this, many companies, as you could see, have developed this artificial skin in the dish. So Apligraf, for example, grow neonatal fibroblasts in collagen matrix that develop into neonervis over time that, one could envisage could be used for wound repair. So these are actually very advanced technology that we could exploit. Regenerative medicine, however, informally started about 60 years ago with the first successful organ transplant performed in Boston by a team led by Dr. Joseph Murray that saved a patient with end-stage organ disease. So Murray also performed allogeneic kidney transplantation from a non-identical twin and from cadaver, and he was awarded the Nobel Prize in 1990. So sharing the prize with him is Dr. Don Thomas, who performed bone marrow transplantation in the late 1950s and 60s to treat leukemia patients. This was followed by renowned immunologist Robert Good's effort to treat an immunodeficient patient with allogeneic bone marrow transplantation derived from his siblings. So this is a very important milestone. And when you think about transplantation, I'm sure some of you may be wondering that if brain transplantation may be possible, It's actually quite a preposterous proposition, but is it possible? Now, the first successful brain grafting was actually done way back in 1890 by Dr. W.G. Thomson. He had transplanted cortical brain tissues of cats into dogs. Now, in the absence of immunosuppression, this is what we call xenotransplantation, and of course, it will not work because of immunorejection. Now, apparently, he had no such expectation either, saying that he was more interested in the vitality of the brain tissue and the cause of its degeneration rather than regeneration. That's that. And if you fast forward to today, I was actually quite shocked to learn that head transplantation had been performed recently in China by Dr. Xiaoping Ren from Harbin Medical University in collaboration with Dr. Sergio Canavero. So although this was performed in cadavers as proof of principle, it was documented as the first successful head transplant being performed in humans. I was equally shocked, if you could see the manuscript submission and acceptance date, to learn that the manuscript was accepted in less than a week and published just a few days later. So I was wondering where this is heading to. Anyway, the main topic that I have been wrapping my head around for a long time is Parkinson's disease, which is the fastest growing neurological disorder in the world, expected to hit more than 10 million individuals in just a decade. Now in Singapore, our prevalence is comparable to that of Western country, and it doesn't matter if you are a Chinese, a Malay, or an Indian, we have equal opportunity of getting this disease. The lifetime cost is not trivial, especially for elderly patient, because the patient need to visit the hospital frequently to have their medication adjusted. Now, many are depressed, as you could appreciate. They experience very poor quality of life. Unlike a pandemic, PD will not go away, and Parkinson's patient will not recover from the disease unless we can think of innovative ways to mitigate the progression of PD. So clinically, the disease is attended by a series of motoric deficits, including bradykinesia, which is the slowness of initiating movement, a marked resting tremor, a cogwheel type rigidity. So with this triad, you can imagine that patient, tends to have very unstable posture and has the tendency to fall. The underlying neuropathology that gives rise to this constellation of motoric deficit is the rather selective and progressive loss of dopaminergic neurons in an area of the brain known as the substantia nigra. So this contains neuromelanin. They are otherwise known as the black substance. That's what Latin substantia nigra means. And you can appreciate the dramatic loss in the PD brain. Now, given that the primary neurochemical alteration in the PD brain is the depletion of dopamine, you can appreciate that replacement of dopamine via the administration of its precursor levodopa, because dopamine does not cross the blood-brain barrier. So levodopa treatment remains the gold standard treatment up to today. It has been more than half a century, and we are still using this drug as the gold standard. The problem is this, that after prolonged usage of the drug, it leads to this very debilitating condition known as dyskinesia. So from poverty of movement, now you get excessive, uncontrollable movement. So pardon the noise from the video, you can appreciate, the marked tremors both in the upper and lower extremities and the failure of this individual to close the mouth. I am sure we all feel very sorry for this gentleman. Now, when you think about what is it, that actually cause all this motoric deficit in PD patient, what is the brain circuitry defect? It is actually quite straightforward. The substantia nigra dopaminergic neurons actually normally project to a subcortical structure known as the striatum that is comprised of cortex and putamen. This is what we call a nigrostriatal pathway that is important for motor coordination. Now, in the absence of substantia nigra dopaminergic neurons, as you can see in Parkinson's patient, the overall result is this excessive inhibition of the thalamocortical circuit that results in poverty and uncoordinated movement. So the next time when you carry out an activity, think of the consequences of unanticipated sudden freezing of your movement, and you can appreciate, what PD patients are going through on a daily basis. It's like a prisoner trapped in his own or her own body. Is really frustrating. Now, you and I could think of the 3 general therapeutic strategies to treat PD patients more effectively given this pathology. The first is to prevent further loss of dopaminergic neurons in the brain through neuroprotection. So, for example, we could treat them with NER1 inhibitor that actually is important for dopaminergic neurons maintenance that Joe Yun's group at NTU and we have recently reported. You can also appreciate that the brain is an elaborate network of electrical circuits. So potentially we can fix the faulty brain via deep brain stimulation, which is currently practiced. So to augment this, we are also developing near-infrared stimulation that could be neuroprotective at the same time. And finally, most relevant to today's talk is to replace the lost dopaminergic neurons through regenerative medicine. Now, because Parkinson's degeneration involves, as you can appreciate, a rather circumscribed region of the brain. So it has been a popular proof of concept model for regenerative medicine. And let me walk you very briefly through the history. So historically, fetal ventral midbrain grafts that contain dopaminergic neuroprogenitors, they were used. So this was first performed in Lund in Sweden in 1987, and subsequently through the 1990s. Each of these patients received 3 to 6 aborted fetuses derived tissue on each side of their brain. Now, however, the results were variable and the efficacy were really difficult to interpret, although the investigators were overall positive. Their optimism is actually not unfounded because longitudinal studies using PET imaging, as you can appreciate, from the figure on the right, revealed that dopamine release was sustained for a very long time in the graph. For more than 10 years, and more recently it was reported some of them actually persisted for more than 20 years. So there is actually room for optimism. But however, as we witnessed a new century, things began to take a turn. So when President Bill Clinton passed a law to allow funds to be made available for US-based study, 2 very high-profile NIH-funded studies were conducted. Now, importantly, both these studies were double-blinded controlled trials that were necessary to assess whether the grafts were really efficacious or were they just eliciting perhaps some placebo effects. So here's a summary of the 2 NIH trials. So the overall conclusion is that really there's no significant improvement in the primary clinical endpoints. It really does not improve the motor features as measured by this standard Unified Parkinson's Disease Rating Score. The other note is that a significant number of the transplanted patients experience dyskinesia akin to the video that I've shown you just earlier. Very likely, this is due to serotonergic neurons contamination because fetal grafts are not purified of dopaminergic neurons. They do contain serotonergic neurons that could give rise to dyskinesia. And PET imaging indeed revealed that the transplant actually contained dopamine terminal in a very competent fashion. So there is now this conundrum of lacking of correlation between clinical benefits and the survival of the transplanted cells is actually a nagging concern. But all in all, younger patients and patients with less advanced disease, they tend to perform better. So the overall conclusion is this, that patients at earlier disease stage with no significant ventral striatal DA degeneration and negligible dyskinesia, they may be the one benefiting from fetal graft. But importantly, it is a proof of concept that support regenerative medicine for Parkinson's that may be beneficial if you especially have a way to purify the dopaminergic progenitors. So despite this setback, Europe continues to be very optimistic. The investigators involved in fetal cell transplant, in fact, has come together to establish the Trans-Euro network to continue with the procedures with 11 more patients. So this is led by Roger Barker from Cambridge, and they have provided an update recently in Nature Medicine. Now, notwithstanding the optimism of Trans-Euro, you probably could appreciate many issues that we need to grapple with when using fetal with ventral midbrain tissue. So number one, as I've alluded to, is tissue availability. I was saying that, around 3 to 6 body fetuses need to be collected and transplanted into each hemisphere of the PD brain. And the cells remain viable only for a very short time. So many surgical procedures were canceled because of the lack of sufficient amount of tissues. The other, as I've also mentioned earlier, is the heterogeneity. So if you have contaminating serotonergic neurons, you will have a lot of graft-induced dyskinesia. So like I say, from poverty to excessive movement, and that's not good either. It's a very bad side effect. And of course, there's these problems with standardization. So despite SOPs to ensure that cells are of highest quality, the fact is that there is variability across different fetuses. They are intrinsically different. And finally, last but not least, you have lots of ethical consideration to grapple with. There is therefore a need for alternative cell sources. And fast forward to today, of course, thanks to the discovery by Nobel laureate Shinya Yamanaka, we now could generate induced pluripotent stem cells from an individual by just taking, for example, your skin cell and turn them into stem cells, and thereafter practically any cell that we need for regenerative medicine. Never mind the promise that some say that stem cell therapy could also make you younger, but that's that, huh? Now, an important milestone reported by Jun Takahashi in Kyoto is the use of human iPS cells to treat experimental PD in monkeys. So Jun's lab actually used a modified protocol that involved culturing of the iPS on laminin and selection using the floor plate marker corin. So you could appreciate, from the images on your right, these are non-human primates brain sections. They produce beautiful graph in the striatum of the monkeys, and the PET imaging below actually shows you that the graph produced dopamine and persisted actually for at least 1 year post-transplantation. So this is really a advance in the way we could apply regenerative medicine using iPS on PD patients. And June, 1 year later, started the first iPS human trial for PD in Japan. Actually, his wife, Dr. Masao Takahashi, actually beat him to claim the first human iPS trial in Japan, I beg your pardon. But for another condition known as age-related macular degeneration, but notwithstanding the promise that iPS technology holds, there are several issues as well that present significant challenges to its routine use in the clinic. So yes, you can do autologous transplantation by taking your own cell, putting it back into your own body. But in order to generate clinically grade cGMP compliant cells, it takes huge expenses. We are talking about several $1 million per iPS line to generate clinical grade iPS. So this, would be prohibitively too expensive for routine application in the clinic. Now, if you are talking about allogeneic transplantation, of course, from a different individual, there will be a high risk of immunorejection. So this is a conundrum because, if you have a cell type that can be applied to different individuals, I think we are in business. But if you have to take your own cell and every individual have to take their own cell, like I say, it's too expensive. So one way perhaps is to screen for HLA matched donor for allogeneic transplantation. And this is what is being done in a few countries, including Japan. Now, even in Japan, this represents a mega financial and logistic undertaking, notwithstanding that they have actually a far more homogeneous population than ours. So you can imagine that this is going to take a huge amount of financing and effort just to get the HLA typing that is suitable for certain individuals. And if you take cells from Parkinson's patients that are typically in advanced age, you could appreciate that they will be plagued with mutation just by virtue of the interactions between the cells and the environment through the sense of time. So what do we need? Now, what we need is a hypoallergenic tissue that is both somatically pristine and that can act as a universal source of donor cells. But where can we find these magical cells, right? Now, so this is where we came in, and we'd like to thank NRF for their support of our CRP grant in positioning human umbilical cord lining derived cells as a universal source for regenerative therapy for Parkinson's and other disorders. So, when you think about this, when you think about surrogate motherhood, you would appreciate that a woman will be able to host a fetus of any race and nationality. So what does this tell you? It tells you that the umbilical cord must represent an immunoprivileged interface. Can we not take advantage of that? It so happened that our collaborator at Cell Research Corp has proprietary technology to derive cord lining cells for which they have patented. So they have further shown in their in vivo study for wound repair that these cells are safe and they possess immunomodulatory properties. So what we have done is that to enhance their stemness, we propose to generate iPS from these cord lining cells. So imagine they are immunoprivileged, I beg your pardon. If the immunoprivileged property persists to the iPS, then I think we are in business. So relevant to this, we have previously reported in collaboration with Dr. Andrew Wan from A*STAR, a xeno-free, feeder-free, and viral-free method for generating human iPS that would improve its clinical utility, from which we have differentiated into midbrain dopaminergic neurons. So we have used plasmid containing the Yamanaka factors for this purpose. So they work very well and they are much cheaper than the current Sendai virus method. So what we have done is that using this episomal reprogramming method, we have generated, as you could see here, cord lining iPS, or CLIPS for short. And we confirm its pluripotency via staining with various pluripotency markers. And you could appreciate from the DNA gel on your right that the episomal genes, they did not persist in CLIPS as expected. So they're not supposed to be there. After reprogramming, you don't have the episomal vectors anymore, which is good. We also confirm through karyotypic analysis that these cells from different individuals, they do not harbor gross chromosomal abnormalities, and that's important. So as per standard practice, we have further ascertained the pluripotency of CLIPS by performing the Teratoma assay, which you could see from the image on your left top, which shows that they are competent in generating teratoma when injected subcutaneously into mice. Now, alongside this, we also demonstrated that they could give rise to different types of cells representing the endodermal, mesodermal, and ectodermal lineages, including, as you could appreciate here, the formation of hepatocytes, cardiomyocytes, and of course, dopaminergic neurons that register the characteristic electrophysiological profile. Now, some of you may also be interested to note that we have also generated oligodendrocytes, as shown in the bottom images, which would be of utility for some of your experiments. So next, we were curious to know how CLIPS potentially behave in vivo. So for this purpose, we have utilized the technology developed in Ng Hak Hui's lab together with E.K. Tan and Sean J. You could appreciate that we now could grow 3D mini midbrain in culture from iPSC derived from any individuals. So importantly, these organoids contain dopaminergic neurons that are neuromelanin enriched. Remember, substantia nigra pars compacta stands for black substance because they contain neuromelanin. So for the first time in vitro, these organoids could recapitulate what is in the human brain, which I thought mimicked the human substantia nigra rather faithfully. So in collaboration with them, we have recently reported that 3D organoids derived from Parkinson's patient, they exhibit age-dependent dopaminergic degeneration, as you could appreciate here. So using the same protocol developed by ACTRIS lab, a very talented PhD student in my lab, YJ, she started growing midbrain organoids with clips, and alongside, of course, with the adult skin fibroblast-derived iPS or ASF. So when you look at the images on your right, you immediately could appreciate that clips-derived organoid, they tend to develop faster. The important thing is this: by the time they reach 60 to 80 days in culture, they register more dopaminergic neurons compared to those derived from adult skin fibroblast iPS, both 60 days as well as 80 days. So what does this suggest? It suggests that CLIPS dopaminergic neurons actually display enhanced survival in vivo in the context of a 3D brain that mimics the human brain. So we are now investigating the mechanism underlying the enhanced survival, but it does, provides us with encouragement that we could use these sorts of cells for transplantation and they will survive well. So to evaluate their utility for transplantation, we need to generate a suitable animal model, and we have generated the standard 6-hydroxy unilateral lesion mouse model. So what happens is that following the injection of this PD neurotoxin, in this case into the left striatum, remember the nigra striatum pathway, striatum is where the dopaminergic terminals actually innervate to form the nigra striatum pathway. You can appreciate, once it is administered with the toxin, the visible, this loss of Th positive dopaminergic neurons in the striatum, as well as the cell body in the substantia nigra. So because this unilateral lesion will lead to an imbalance in dopaminergic output, the animal will start rotating if you applied it with a dopamine releaser, such as amphetamine, which, by the way, you need police license in Singapore to get the amphetamine, or dopamine agonist known as apomorphine. So you could see here that the lesion mouse, after administered with amphetamine or apomorphine, they start rotating. And this is a very, very convenient readout. So as a further refinement of this model, the images on your right, we now have successfully injected this neurotoxin also into the substantia nigra region of the brain of the mice. Now, why are we proud of this? Because it is actually a very, very, very small nucleus in the mouse brain, and it takes exquisite expertise. So what happened is that this approach targets the cell body of the dopaminergic neurons, and in doing so, it will eliminate the confounding factor of spontaneous recovery in the striatal lesion mice, because the terminals potentially can grow back unless you hit the cell body, which in this case, of course, we are doing so. Like I say, it needs exquisite skills. And we are lucky to have a neurosurgeon resident, Dr. Aaron Fu, on board, who has mastered this technique. My lab research assistant, Hui Ching, similarly has acquired this technique. So we are ready to go. So before rescuing the lesion animal, we first have tested their survival in immunodeficient not-skid mice, just as a proof of concept. So images on your top right-hand corner, what it shows is that both skin-derived iPS as well as CLIPS dopaminergic graft, because these are immunodeficient, so they will not be rejected. And true enough, all of them survive in the striatum of these mice. The litmus test is this. Now, what follows is that we use, instead of immunodeficient mice, we use immunocompetent C57 mice without immunosuppression. Okay, so this is xenotransplantation without immunosuppression. We are asking for trouble. So we hypothesize that if CLIPS-derived dopaminergic neurons are truly immunoprivileged, now they should engraft and survive better than those generated from adult skin fibroblasts in an immunocompetent host. And indeed, this is what we have observed, as shown in the images below. You can see on your left, CLIPS engrafted really well and generated TH positive neurons in these mice and sent projection down, And on your right, meanwhile, those engrafted with skin iPS, they virtually were rejected. You can see no engraftment whatsoever in an immunocompetent mouse, as distinct to when you do that in the immunodeficient mice, the not skin mice. In this case, it does support our proposition that CLIPS exhibit immunoprivileged property. Now, alongside this, let me try to convince you further. We also recorded progressive improvement in the rotational readout in CLIPS engrafted mice compared to those transplanted with skin iPS or sham mice, especially from week 20 onwards. Let me show you the video. Which I'm sorry, failed to work. I tested just now, it was okay. Maybe I'm talking about Parkinson, so everything tends to freeze. Never mind. You could appreciate from the bar graph that indeed at around week 20, you see significant improvement between those injected with CLIPS and those injected with skin-derived iPS. But the important thing is this: in collaboration with Professor Balas from LKC, we also carry out PET imaging studies, and you could appreciate the loss of PET signal in the lesion site of the mouse. But what happened, when they are engrafted with CLIPS-derived progenitor? You could see here that the PET dopamine signal is approaching that of the naive animal. So meanwhile, those injected with adult skin fibroblasts, they are as bad as the sham control. So the imaging study, just to let you know, will perform at 6 months post-transplantation. So what it tells us is that not only does it lead to functional recovery, indeed, they produce competently the dopamine that is needed. Now, let me just call it back to the slide mode. Okay. Now, we are also happy at the same time to note that the TH positive dopaminergic graft, I was telling you 6 months earlier, they persisted over a 9-month post-transplantation period. And may I emphasize again, without any immunosuppression regimen. And importantly, without any apparent tumor formation. So what this result actually suggests is that, we have long-term efficacy, and it is, potentially very safe approach. So although these results were very promising, we wanted to make sure that it's not species-specific phenomena. So we have also replicated our findings in the rat. And as you can see, as we have seen in the mouse, the rat that is actually engrafted with CLIPS neuroprogenitor, in terms of rotational deficit, they actually show much improvement. And when you look at the engraftment on the images on your right, you could see, very beautiful engraftment showing up the TH positive neurons. So both in the mouse as well as in the rat. And we are proceeding, of course, to embark on this study in non-human primates as well. But the million-dollar question is this: that what makes CLIPS immunoprivileged? So currently, we are trying to find out this mechanism. So we were originally thinking that maybe neuroinflammation would be subdued in clip transplanted mice. But to our surprise, we actually documented quite abundant this IBA positive microglia aggregation in the transplanted hemisphere that is absent in the non-transplanted hemisphere. Now, higher magnification, you could see in image K and L, it shows that the microglia located proximal to and also inside the graft, they display a more amoeboid morphology that is characteristic of activated mitochondria, of microglia. And they express CD68, which is an activation marker for microglia. So I'm just thinking that perhaps CLIPS-derived neurons could somehow find a way to evade the attack by microglia, which is very interesting. Or maybe those microglia surrounding CLIPS, not the bad microglia, the beneficial microglia. So we're trying to deep dive into this. But alongside this, we also perform an immunologic profiling with the usual suspects like HLA, CD40. We actually found disappointingly nothing too dramatically different between CLIPS and adult skin derived iPSC and also the progenitors. So again, we are now trying to do some RNA-seq. We're trying to really get into the mechanism, notwithstanding that our progress has been impeded, like all of you, by the pandemic situation. But hopefully, over the course of the next few months, we could make some tangible progress in that. So before I end, I just wish to highlight that we are part of this multidisciplinary team comprised of basic scientists, of clinician scientists, of engineers, as well as industrial partners, targeting not just at Parkinson's, but also at age-related macular degeneration. So in particular, Team PI, Dr. Sue Cindy, she has made amazing progress for her AMD studies, both in rabbits as well as in monkey. I was talking about mouse and rats. We have for AMD, rabbits and monkeys. So we have 4 different species supporting that CLIPS is immunoprivileged. So I hope that she'll be able to share her work soon with all of you. And recently, we also have the pleasure of collaborating with Chu Xingyan as well as Ng Xian on using CLIPS to treat spinal cord injury. I just wanted to shout out that we welcome collaborations from everyone. So let me end here by thanking my lab members, collaborators, and funding agency for the work presented. By the way, we have recently patented this technology. And thank you very much for your attention. I leave enough time to have a good Q&A session. So happy to take any question. Thank you very much once again. Back to you, Estila.
Thank you so much, Prof. Lin, for your wonderful sharing. I think there is a question from the Q&A. It's from Simon. Thanks for the talk, Prof. Have you determined whether the CLIPS transplants are susceptible to Lewy body formation like the endogenous dopaminergic neurons?
Simon, it's a very good question, and it's a very valid question, as has been shown by others transplanted with the fetal graft, that indeed after prolonged period, you have a transmission of alpha-synuclein positive Lewy body. So we haven't quite reached that stage yet. I don't know whether if CLIPS for some reason may be resistant to the Lewy body formation by virtue of alpha-synuclein infiltration. But having said that, it does take actually quite a prolonged period. In fact, when they reported those studies, it was more than a decade before Lewy body starts to form in the transplanted neurons as well. So in practical sense, I think, the regenerative medicine approach does buy the Parkinson's patient quite a bit of time, especially considering that most of them are in advanced age and stages of the disease. But this is a very interesting line of thought. If CLIPS, for some reason, is resistant to Lewy body biogenesis, I think that would be even better. Yeah, so I would have to get back to you on this by doing the experiment and waiting for the Lewy body transmission.
Thank you, Prof. Lim. Okay, any other questions from the audience for Prof. Lim? I think it's been a very interesting talk. It was very detailed in sharing. Okay, okay, there's a question from Dr. Tan. For late Parkinson's, do you think clips will work?
For late Parkinson's, I think generally speaking, regenerative medicine is probably the approach that one would take. For early Parkinson's, usually we will want to take a neuroprotective approach. Now, early Parkinson's, actually, just to elaborate a little bit, when a patient is diagnosed with Parkinson's disease, usually around 60 to 70% of the dopaminergic neurons has been lost in the brain. So what does this tell us? This tells us actually, imagine, you need to lose around 60 to 70% of your dopaminergic neurons before you exhibit clinical manifestation in an overt fashion that will requires you to see a neurologist. It tells you there's a certain element of redundancy. And it also tells us that if we can protect degeneration from further occurring, or better still, if you have prodromal markers that let us ID the disease at an earlier stage and then apply neuroprotection, you have really a good chance to prolong the patient's quality of life for a good number of years. So on the other hand, if you go now to advanced stages where practically 90+% of the neurons has been lost, replacement through regenerative therapy is probably the best approach. Of course, we have deep brain stimulation. I'm not suggesting that deep brain stimulation is actually not a good approach. However, deep brain stimulation is only relevant to a subset of patients. So regenerative therapy needs to come in as an alternative approach, especially for advanced PD.
Okay, thank you. More questions coming in. Another one from Xiaoming. Great talk, Prof. Lim. May I know if EC23 clips cells affect dopamine production by host neurons?
Yeah, I just wanted to shout out to Xiaomeng. We missed you at LKC Medicine. Hope you are, doing well, which I'm sure you are at DON-US. So your question about clips affecting dopamine production by host neurons, I am just trying to figure out what you mean. As in, if we transplant clips, would the neighboring dopaminergic neurons in the host be nudged towards producing dopamine? Is that right? Xiaomen, are you in the audience? Maybe you could just...
Yes, he said yes, correct.
It's correct, huh? Okay. We haven't got to there yet. It's an interesting proposition, whether there is this paracrine effect. Huh? And I'm just thinking of mechanistically, how that would happen. Suffice to say that I don't have the answers to your question, Xiaomeng, at the moment, but it's certainly a very interesting proposition. Although, on the other hand, pathogenicity can be transmitted from diseased neurons to transplanted neurons or to healthy neurons in vivo. What you're asking is in a reciprocal fashion, whether there is benefit in a healthy neuron over a neuron that is not so healthy. It's certainly very interesting. I would want to further, I guess, state that perhaps not interneurons, but the glial cells in this case will play a very important role.
Great, thank you. Another question from Jeffrey. Thanks for the nice talk, Jeffrey. Here, if I'm not wrong, you showed the clips derived DA cells have improved survival. Other than survival, any other difference, such as the neuron's development, maturation, function, etc., which might be important for the therapeutic effect in clinic?
Jeff, thanks for the question. It's actually a question that we have been thinking about more recently, and which is the reason why we were looking at these properties in the 3D midbrain model. So it's actually it's a fairly recent study, but you could appreciate from the slide just now that indeed we do see accelerated development. We do see especially survival in the aged midbrain. So the other thing that I hope Xingyi would not mind me sharing is that in her case, she also see that clips can actually promote the differentiation of retina pigmented neurons, RPE, that is needed for cell therapy for age-related macular degeneration. So if you put both side by side, it does give us the optimism that the clips has some properties that also can help accelerate the maturation of the differentiated cells that we need. So at the moment in time, this is the observations that I could, I guess, respond to your question. I hope that is fine.
Okay, thank you. Another question from Shaw Tian. Great talk, Prof. Lim. The approach sounds fantastic. Is there any clinical trials planned for clips for PD or AMD or any other neurological diseases?
Hey, Shaw Tian, good to see you. Thanks for attending the talk. So indeed, our CRP funds, we plan in the 4th and 5th year to generate clinical grade this clips for first-in-man trial. So that is in the works. So as I have mentioned, we have patented this, but as that, the important thing is that we need to make sure that we have consistently good quality clinical grade clips that we could use for transplantation. So as an interface, as I was alluding to, we will be moving very shortly into transplantation in marmosets, non-human primate, as a proof of concept that we can move on to conduct clinical trials. For AMD, the same. Xingyi also plan to conduct clinical trials in around that time frame.
Thank you. Next one from Kai Cheng. Super exciting work. What is your vision for these treatments being administered clinically? Will these have to be lifelong treatments? Will they need to be injected directly?
Yes, we envisage that it would be a prolonged treatment, which is why we have been following the course of the graft in the animals for extended period. I was showing you the 9 months data. We need to actually really observe it throughout the whole course of the animal life. But 9 months in the life of a mouse is actually pretty extended already. Necessarily, it needs to be prolonged because the transplantation of cells into the brain, it is not your everyday procedure. So we try not to subject patient to multiple injection. So what we are hoping for is that the graft would survive and would survive for a very long time, as we have seen in the animal. So that's what the fetal ventral midbrain transplant also revealed, that in some patients up to 10-20 years you still see competent this dopaminergic graft producing dopamine. So that's our intention.
Okay, I think that's all for the questions. Any more questions from the floor? Thank you, Prof. Lin, for all your answers. I think it's been a very insightful talk.
And thank you very much, Estela, and also everyone once again for spending your very precious lunchtime with me. I hope it has been a beneficial session for all.
Thank you, thank you. Yeah, thank you everyone's attendance, and it's been wonderful. Also, your questions has been insightful as well. Thank you, Prof. Lim, once again. I hope the rest of you enjoy the session sharing by Prof. Lim. Till we see you next time at the. Okay, there's one more question. Oh yeah, thank you, Prof. from Dr. Tan. Okay, thank you, everyone. I hope to see you again next month for our webinar. Thank you.
Yeah, have a great day ahead and stay safe and well, everyone. Goodbye.
Okay, bye bye.
So thanks again, Estela, for hosting this session.
Thank you. Thank you. Thanks,
I will
everyone.
take my
Bye-bye.
leave.
See ya.
Yeah.
Bye-bye.
Bye-bye.